Today I'm dealing with the topic of soft contact lens fitting and assessment, soft toric contact lens fitting and assessment, and RGB contact lens fitting and assessment. So before I go into the topic, I would like to thank KSOS and the chairperson Vijay ma'am and the moderator Seena ma'am and also Dr. Soumya Nambiar for giving me an opportunity to have this talk. So basically, I'll go with what is a contact lens. Contact lens is an artificial device whose front surface will be substituting the anterior surface of cornea. So it's mainly used for the correction of refractive error, irregularities on the front surface of the cornea. So basically, it is considered as a medical device. Classification of contact lenses. There are many classifications based on the anatomical positions, wearing modality, water content, and the material basis and the replacement schedule. So mainly I'm talking about on the material. Material basically soft contact lens, RGB contact lens. So soft, hydrogel and silicon hydrogel, RGB lenses, and there is also a hybrid lens where RGB is in the center and it is surrounded by a soft silk skirt. And also based on the replacement, we have the daily disposable, bi-weekly, monthly, quarterly and conventional lenses. So indications mainly to whom we can give contact lenses is optical mainly for the refractive error corrections of myopia, hypermetropia, astigmatism, uniocular aphakia and also irregular astigmatism and keratoconus. Mainly for therapeutic, for treating any corneal ulcers or for any trichiasis, entropion, ectropion, etc. And for occupational, mainly for the sports people or also for the pilot and also for the actors. And for the diagnostic, mainly we will be giving for gonioscopy and also for the cosmetic purpose if the patient wants color contact lenses, and also for any phthisis bulbi etc. will be treated with cosmetic lenses. So basically there are two fitting criteria for contact lens fitting, mainly the empirical fitting and the diagnostic trial lens fitting. So empirical fitting requires only the patient prescription, corneal diameter and also the corneal curvature. So it's very quicker and time efficient that we don't require a trial lens fitting. We have the prescription, we can fit for the patient. If it comes to a diagnostic or trial lens fitting, it's mainly based on the preliminary examination that the patient have to undergo, and also there should be a good lens cornea relationship with the design what we choose, and finally we have to confirm the final RX which is required. So it will be very helpful in choosing the initial trial lenses. So these are the contact lens workup protocol criteria where we have to undergo before examining the patients. So there should be a preliminary examinations and parameter selection, patient selection, trial lens selection, fitting assessment, over refraction and contact lens dispensing. So there should be a preliminary examination, that is thorough history taking of the patient is very important, where we have to know the previous ocular history and the patients who is previously wearing the contact lenses, and whether what is about their occupation and also the working environmental conditions. So after that we will be coming with the visual acuity, refraction, tear film. Tear film is one of the basic important preliminary examination if it is concerned with the contact lens, because if the patient has a dryness, what type of material we have to give will be depending upon the these tests. And also the slit lamp evaluation, that is detailed slit lamp examination whether patient is having any lid abnormalities or any corneal abnormalities or conjunctival abnormalities will be understood from the slit lamp examination and also the fundus examination. So these are the parameter selections where we have the keratometry or the topography report, where topography report will be very important in identifying the location of the cone for especially for fitting for RGB lenses, and keratometry is mainly for selecting the base curve, and HVID is for selecting the corneal diameter, and it is simply measured with a millimeter scale from the limbus to limbus, and also the lid characteristics whether and also lid donors, whether it is very loose or tight or can be understood, and with the palpebral aperture height can be measured with a millimeter scale. So it varies from the ethnicity, from the Caucasian to the Asians, it will be varying. So it's very important to measure the lid characteristics, and also the pupil size, which is very important as far as concerned with contact lens for the optic zone diameter. So in mesopic condition and also in the bright light conditions, we have to measure the pupil size, and also the spectacle refraction, which is very important. If you have to convert the vertex conversion, and also the spherical equivalent can be done with the spectacle refraction, so we'll get an initial calculation for it. So this is the basic conversions where you will get with base curve calculations, where we have to diopter conversions. It is done with f is equal to n minus 1 by r, where we will be getting the dioptric value. So the reverse we can do for the dioptric to get an conversion also. So if example, you can see there is a K1 of 7.8 and also K2 7.70 So first we have to find the flat K. With that flat K we have to add 0.8 So it ranges from 0.6 to 1 So if we add flat K plus 0.8 we will be getting the base curve as 8.6 So also the base curve ranges from 8.4 to 8.9 and diameter 13.8 to 14.5. This is a range which is selling. It depends upon the company. It will varies. And also contact lens selection, base curve, total diameter, and also the back vertex power. So if we are calculating the total diameter, we have to take HVID plus 2 and base curve we have to add 0.8 to 1 to flat K. And back vertex power have to be calculated with the vertex conversion for spectacle refraction plus or minus 4 diopter. And the material can be choose with hydrogels and silicone hydrogels. So there is a case of K1 44 180 7.67 and also K2 is given. So HVID is 12 so spectacle RX is minus 5. So it is calculated with FCL is equal to FSP by 1 minus D into FSP. So it will be giving a base curve around 8.47 and you have to add HVID plus 2 it will be giving 14 So with that FCL we will get the back vertex power as minus 4.75. So after this selecting, we have to check for the fit assessment. We have to give a proper adaptation time for the patient, and also we have to check for the coloration, centration, movement, whether vertical lens sag, horizontal lens lag, tightness of the lens, comfort, and also the stability of the vision. So the coverage usually say full corneal coverage 1 to 2 If it is greater than 2 overlaps, lens will be large. If there is a corneal exposure, there will be lens will be too small. And we have to check for the vision. Vision clears after blink, it is a steep fit. Vision blurs on blink, it is a flat fit. And also push-up test, you have to check for ideal fit will be saying 40 to 60%. So there will be an easy displacement, smooth recovery and recentration. And if it is 65 to 100%, will be saying a steep fit. And if it is 35 to 10%, it is a flat fit. And we have to check for the lateral gaze position. Optimal movement will be saying around 0.5 to 1 If it is a lateral gaze lag, up to 1.5 is accepted. And if it is by looking up to up gaze, if lens slides up to 1.5 it is a well fitted lens. If the lens does not slide, it means a tight fit, or if slides more than 1.5 it is flat or loose fit. So if it is before going to that, we have to know the thumb rule of if there is a 0.3 change in base curve, there is a 0.50 change in total diameter. So if it is a steep fit, we have to increase the base curve or decrease the dia, or if it is a flat fit, we have to go with decrease the base curve or increase the dia. So in order to make an optimal fit. Next we move on to the soft toric contact lens fitting assessment. So soft toric contact lens is gone when the best sphere does not give a satisfactory visual acuity, and when there is a residual astigmatism that is more than 0.75 diopters, and if there is a residual cylinder which causes very discomfort for the patient, and also when the patient is not comfortable with the RGP, and also when the sphere to cylindrical ratio is less than 4:1. So there are some fitting guidelines for every lenses. For soft toric lens, we have to start with the refraction. So you have to select an initial trial lens, and according to that you have to convert the vertex conversion using a vertex conversion table chart. Then you have to perform a keratometry. You have to choose a trial lens closest to the spectacle axis. Then you have to do a vertex distance compensation for the sphere and cylinder. Then we will do a slit lamp evaluation to check for the corneal coverage, centration, movement, etc. Then you have to evaluate the visual acuity. If there is a lens rotation, visual acuity will not be improved by adding any lenses. So you have to check for the axis compensation for it. So axis fit assessment is seen by different companies are shown over here. Here portion long is shown over here, and also different companies having different orientation mark. That is in order to identify how much rotation has happened and how much should be compensated. So same way we will be covering for the centration, coverage, push-up test, movement with blink, lag, etc. So if there is a 10-degree rotation, usually we say LARS rule will be left. There is a from the practitioner side there is a 10-degree rotation, you have to add, and if it is the right you have to subtract. And CAS rule where clockwise you have to add and anti-clockwise you have to subtract. So there is a case where the spectacle prescription is given. Spectacle prescription is given -1 with -0.75 across 180. If there is a 20-degree nasally side, it is rotating, you have to add 20 to that. So the final prescription will be -1 with -0.75 across 20. So there should be any troubleshoot is the lens rotationally stable. So the troubleshoot can be done with clockwise, anti-clockwise, and other stabilization techniques, which I am not going into it. Prism, Ballas, Peri-Ballas, so many stabilization techniques are there. Next, I move on to the RGP fitting and assessment. The same fitting protocol as the soft contact lenses, but extra we have a counseling, because a hard lens it will take for the patient to adapt. So we have to counsel for the patient before we fitting an RGP lenses. So these are some of the astigmatism where how we have to get an idea for fitting a start a base curve selection. So if there is a 0 to 0.75, we will be fitting on the K. If it is 0.5 to 1 diopter, we will be fitting 0.05 mm steeper than K. 1 to 2.5 diopter, we will be fitting 0.10 steeper than K. And if it is greater than 2.5, we will be fitting on the mean K reading. So if there is high corneal astigmatism, we will be moving with the toric lenses. So these are the things, criteria we should be keep in mind before fitting RGP lenses. So we will be fitting a base curve that is flat K or steeper, that is flat K or steeper than the flat K, and we have to take the measurements of total diameter, that is HVID minus 2 mm, where for soft lenses we will be taking HVID plus 2 mm. And optic zone. Optic zone is very important because the pupil size is very important, because optic zone because it is covering coming below that. So we have to cover pupil plus 1.2 mm, and also we have to do a refraction. So these are some of the procedure for fitting RGP contact lenses, where you have a palpebral aperture measurements. Its normal range will be seeing around 9.2 to 9.6 mm. So if there is a small palpebral aperture, we have to go for the smaller diameter lenses, that is 9 to 9.2 mm. Larger aperture, you have to give a larger diameter, that is 9.6 to 10 mm. And keratometry also very important. If the base curve, flatter base curves will be usually needed larger diameters, and if it is base curve steeper, we will go with a smaller diameters. And HVID is very important. HVID we will say an average of 11.76, where the range come around 10 to 14 mm. So mainly the fitting assessment, that is static and the dynamic fitting. So static fitting, dynamic fitting, where we have to check for the position, centration, movement and stability. Then dynamic itself, the word means the lenses is moving. And for the static fit, we have to check for the lens back surface and corneal front surface relationship. So this is a dynamic fit assessment, there where the fitting are observed with the eye in primary gaze and blinking normally. So you have to check for the centration, stable, superior lid coverage, movement. Usually, ideally for RGP lens, we will see a movement of 1 to 2 mm. So this is if the centration is not proper. In the first top, you can see a lower riding and also an upper riding. And the static fit. Static fit when the lens is in the still position, where you have to check for the central zone, and you have to check for the mid periphery, and you have to check for the edge. So if it is an ideal fit, there will be a minimal central clearance, light mid peripheral contact zone, optimal edge width and average edge clearance. So if you have a first picture, you can see a central clearance with thin fluorescence, and in here you can see a central bearing in the B picture, and the C picture you can see a central pooling. So if this base curve, there should be an ideal sodium fluorescent, and if it is pooling, means it is a steep fit. So you have to flatten the base curve, and it is bearing, means there will be a central touch, bearing or central touch, which you have to do a steepen the base curve. So here also we follow the rule of thumb, where 0.05 changes in back optic zone radius will be equal to 0.25 changes in the power. So here the first pictures shows the central pooling, and also there is the thin edge. So it is a picture of a steep fit, and here the next picture shows about the flat fit. So these are different fits showing. The first one very steep fit, where you can see a central pooling and also a very narrow edge of very steep fit. Second one is steep fit, you can see there also steep fit edge you can be seen, and also in C there is an ideal fit, where you can see a central clearance and also a good edge clearance can be seen over there. And the different figures shows the flat fit, very flat fit. And this is the overall summary, where if you have to get a optimum, means central there should be a light touch, and in steep fit there will be a pooling, and flat there will be a touch will be there. And horizontal meridian, if you look, there will be a mild touch and also touch in the vertical meridian, and excessive touch in the horizontal meridian. So it is categorizing how the optimum steep and flat fit should be. And if it is edge width, optimum narrow, wide at vertical meridians. So if it is 0.15, it will be coming around 8.25. Next trial lens will be going like that. So there is a small video showing the soft contact lens fitting, where the centration of the lens coverage. How in lateral case the movement is case. Thank you.
Thank you, Salia, for the talk on monoscleral contact lenses. Hello everyone, I'm back again with a talk on fitting and assessment of corneoscleral and scleral lenses. Now the speaker before me had spoken at length about fitting soft spherical lenses, soft toric lenses and rigid gas permeable lenses, the corneal lenses. Now the lenses that I am going to be talking about is the comes under the specialty lens fitting, right? So these are not regular lenses. If you find a regular refractive value, you don't recommend any specialty lens, because these are specially designed for irregular corneal conditions. So before I move on, we all need to be on the same page and get to know about the terminology of gas permeable lenses. So in our country, in majority of the times when we mention RGP lenses, I fit RGP lenses. Please try to understand that RGP is rigid gas permeable material. So you can have a rigid gas permeable material in a corneal lens, in a corneoscleral lens or a scleral lens. So whenever you mention it, you have to mention it with clarity. Like, what is a corneal lens is one which has a diameter ranging between 8 to 12.5 mm and has all the bearing on the cornea, and there is no tear reservoir. So this is how an RGB lens looks over the eye. If you talk about a corneoscleral lens, it is otherwise known as semiscleral lenses or corneal limbal lenses. The diameter ranges anywhere between 12.5 to 15 mm, and it has a shared bearing on the cornea and the sclera with a limited tear reservoir. So this lens kind of looks like a soft lens over the eye, but the material is a rigid gas permeable material. Talking about the next lens, which is the scleral lens, which is gaining popularity in the recent times because of the advancements in materials and design, which are also called haptic lenses. They are again classified based on the diameter of the lenses as mini scleral and large scleral lenses, where all the bearing area is on the sclera, not on the cornea. It completely vaults or bridges over the cornea. And the mini scleral lenses have somewhat limited tear reservoir capacity, whereas the scleral lenses have unlimited tear reservoir capacity, and this is how a scleral lens looks over the eye. Now you notice that under the corneoscleral lens also I mentioned 15 mm dia. It could be a 15 mm corneoscleral lens, and you can have a mini scleral lens which is 15 mm dia. The difference between the two, it is not the size by which you classify, it is based on the design in which you classify. A corneoscleral lens will have a shared bearing between cornea and sclera, whereas a mini scleral lens of 15 mm will have all its bearing on the sclera. So you need to be very clear about the terminologies of gas permeable lenses before I move further in my talk. So basically the corneoscleral lenses roughly are around the soft lens diameter of around 14.6 mm, and scleral lenses can range anywhere 15 mm upwards until 24 mm also, depending upon the condition. But because of the anatomy of the eye, nasally it is flat and temporally it is steeper, there is a tendency for scleral lenses to show inferotemporal decentration when fitted on the eye. So you need to understand it is basically because of it follows the anatomy of the eye. So talking about the corneoscleral lens or the semiscleral lens design, every lens has a fitting philosophy what you need to adhere to in order to achieve a good fit. So basically when you talk about fitting a semiscleral lens over the eye, you need to have a central clearance at the highest point on the cornea, and the landing zone is inside the limbus with a 20 to 30 micron clearance over the limbus, and it should be parallel to the sclera to ensure that there is tear exchange. Okay, it is never a seal off over the eye, there is tear exchange happening with corneoscleral or semiscleral lenses. So talking about the fitting system, it follows these 5 steps. You need to work on the central fit, that depends upon the base curve that you have chosen. Next you move on to assessing the peripheral fit. Then thirdly the overall diameter, followed by the location and lens movement. So first step is the base curve. So you have to follow the fitting guideline of the manufacturer as to what is the given condition and what will be the first lens or the trial lens. In this case I have chosen the Rose-K XL lens, which is a Manicon product. Okay, so I'm not going to go into the details, but this is what is an ideal central fit if it's a case of keratoconus. Is there a pointer? If you notice, the highest point in a keratoconus case is over here. So you have to achieve a clearance over this area. Whereas in a post-graft case, you see that the highest point is along the periphery of the cornea. So that is the highest point. So whenever I say central fit, central doesn't mean center of the cornea. In an irregular corneal condition, the center is the highest point of the cornea. In the keratoconus, it is the highest point of the cone, whereas in a post-graft case, it will usually be along the periphery of the cornea. So that clarity needs to be understood, because most of us get confused. When I say central, they look at the center of the cornea. So that is not the case in these designs. So the flattest base curve which shows no touch is the base curve that you need to choose for a corneoscleral lens design. This is not based on the sagittal depth but on the base curve. I am talking about corneoscleral lenses. So this is how the lens would fit in a post-LASIK case with ectasia. You see, as the eye blinks, there's a dark area which might be mistaken for an area of touch, but with blink you see enough fluorescein circulating beneath the lens. So this is an ideal fit. Also, you need to have an optimum edge lift, right? So there the vessels are not camouflaged or impinging, so they should all run and it should be visible beneath the edge of the lens. So conjunctival vessels should be visible. So if there is insufficient fluorescein along the edge, you need to increase the edge lift. If there is excessive, you need to decrease the lift. And a fluorescein band may be irregular if peripheral astigmatism is present. So before I even say that you go in for a corneoscleral or scleral lens, corneal topography mapping is very important. That gives you an idea of the profile of the cornea. That will help you choose the right design, whether it is a prolate or an oblate cornea. Based on that, your choosing of the lens design becomes imperative. So this is an ideal lift where you see enough fluorescein along the edge. There is no impingement or blanching of the conjunctival blood vessels. So judging the peripheral fit, so like I said, corneoscleral lenses, there is a shared bearing and there is no edge seal-off happening. There should be ample tear exchange happening by the edge of the lens. So this is a simple test to ensure that there is 360-degree exchange of tears happening by instilling fluorescein and trying to push the fluorescein. If it's easily entering under the edge of the lens, that means adequate tear exchange is happening. If considerable force is being applied to push the fluorescein beneath the lens, then probably it's a tight edge which requires an increased edge lift. So ideal diameter should be 1.3 to 1.5 mm beyond the limbus. Okay, it is somewhere close to your soft contact lens diameter, I would say. So again, you can have the liberty of increasing or decreasing the diameter based on the HBID of the patient. So lens movement, the ideal lens movement is just discernible. You don't have to have great movement with the lens, because otherwise it will not function properly. So you need to judge the movement at the 6 o'clock meridian, especially if you see at the slide on to the right, where the patient is asked to look up and blink. So on first insertion the movement will be more, but as the lens settles down with time, a 0.5 to 1 mm becomes too much. So the movement should be just discernible. And excessive movement becomes very uncomfortable for the patient, and there could be differences in vision also. So this is a case, the left video that you see is a case of excessive lens movement, and the one to the right is hardly any movement. So both are extreme cases. You want just discernible movement in your corneoscleral case. So this is a very simple case of a 14-year-old male with early keratoconus post C3R. Refraction, the refractive condition is minus 1.75 with a minus 3 axis, 85, 69 partial vision. And mean K values have given over here. So he was advised a contact lens trial. So what I see with the recent, very many designs have entered the market, especially with scleral lenses. So as practitioners, everybody jumps into fitting the scleral lens first. So as a practitioner, you need to be very mindful. Scleral lens should be the last design that you ever choose. You should always start with a corneal rigid gas permeable lens and see if it's working for the patient. If this doesn't work, I move on to my corneoscleral lens design. If that doesn't work, then I move on to the scleral lens. So even for an early case of keratoconus, I see people or practitioners, jumping into fitting a scleral lens, which is not at all required. Every lens has its own pros and cons, and remember, these are compromised corneas. You need to maintain the integrity of the cornea. The corneal health is very, very important as practitioners. It's not about improving vision, it's about improving the quality of vision for our patients that we need to look into. Right? So this is just to tell you that not every case requires a scleral lens. That's the reason why I have given this condition, because keratoconus scleral lenses has become a mantra for most of the contact lens practitioners in the country today. So this is again a case, 37 years old male with post PK. So there are specialty lenses with a post-graft design available. So our first lens, as you see the topographical picture, the periphery is extremely steep. and it is quite decentered also. So as a protocol, I usually try a corneal RGP lens design first. So when I tried, the lens fit was not really great. If you see, the vision of this patient was 612 partial. I really don't go by vision, to be honest. I need to have the fit of the lens good, not compromising the cornea in any which ways, and then comes the vision. Right? So it did give 612 vision, but the lens was rocking over the cornea because of the profile of the cornea post penetrating plasty. The corneal lens was not an ideal lens. Nevertheless, I did give it a try. So the next option was to try a semi-scleral or a corneoscleral lens design. So this gave me a really good fit, and the vision also, you see, there was a drastic improvement in vision from the corneal lens design, and the visual acuity was 6/9 N5. So this was the final lens that we gave for this patient. Moving on to scleral lens, just like every lens has its fitting philosophy, scleral lens also has its own fitting philosophy. So basically, if you see, look at the indications for scleral lenses for ocular surface disorders, irregular corneal conditions, and for high refractive errors which can otherwise not be fit with a regular corneal or a corneoscleral RGP lens, you can give a scleral lens. So the fitting principle is to achieve the scleral zone alignment, because all the bearing is over the sclera. So you have to achieve scleral zone alignment with minimum corneal contact. Okay. So you also need to understand the profile of the cornea. So because these lenses go beyond the limbus, so it is not just the corneal topography, the scleral topography also needs to be understood in all our cases. So when you talk about the design of a scleral lens, it usually has a spherical optic zone, a transitioning aspherical zone, followed by a spherical scleral zone. So there is no method to calculate the scleral zone radius. Basically, when you fit a scleral lens like a corneoscleral lens or a spherical RGP lens, you go by the base curve selection, right? But in a scleral lens, you don't go by a base curve selection, because the lens completely vaults or bridges over the cornea. So you go by the sagittal health, sagittal depth. So every manufacturer will have his own fitting guidelines, but majorly it revolves around the sag height only. So you have to look at the profile of the cornea and decide whether you need to go for a low sag, mid sag, or a high sag value. Okay. So scleral alignment is very important. So you should have optimal apical clearance with aligned scleral curve. The figure 5 and 6 shows excessive apical clearance with a steep scleral curve, and the figure 6 is an optical apical clearance but with flat sclerals. Both are extreme conditions and not advisable to go in for such fits. Also, you need to ensure that there is adequate limbal clearance, because it vaults over the limbal zone as well, and the lens should demonstrate clearance at and extending beyond the lens limbus in order to protect the stem cells and reduce the risk of hypoxic events. Sometimes there is compression at the limbus, so that could also end up with corneal edema, because there are debris collection and then there is reduced oxygen reaching the cornea, so there could be a contributing factor. So you need to look at these aspects. Adequate corneal clearance is definitely required. So these are few examples of central fit where you see, where there is a compression of the apical contact. Okay. So how do you assess the central vault? So there are very, very many fitting scales that are available. You can Google for it and you can compare it. So initially, when we used to fit scleral lenses, we used to compare the clearance based on the thickness of the cornea, but that's not recommended. Now every trial lens comes with the central thickness of the lens. I'm actually combining two talks, so maybe get some extension of time. I'll just wind up as soon. So you need to compare the contact lens thickness with the clearance. So that will give you an idea whether you have adequate clearance over the cornea or not. So minimum 200 to 300 micron clearance is recommended. So what are the 5-step fitting approach for scleral lenses? First is the diameter selection. Second is the clearance over the cornea and the limbus. The landing zone fit. assess the lens edge and then the surface design or customization. You can ask for toric periphery or a quadrant specific edge lift or an asymmetric corneal technology or a notch on the lens in case of a pinguicula or a filtering bleb which is noticed because it is extending way beyond the limbus. So you observe the eye from the side to choose the diagnostic lens with low, medium or high sagittal height. This is more than enough. Sometimes there is too much of scarring over the cornea that a topographic picture availability would be questionable. So in that case, you just have to look at the profile of the cornea and choose your lens from the trial kit. So there could be some potential scleral lens related causes for corneal edema like inadequate limbal clearance or a material related issue or a central thickness issue. So you need to troubleshoot based on what is causing that corneal edema and take the necessary measures. So there could be a case of limbal wearing, so you can increase a scleral lens diameter to increase the limbal clearance, increase the sagittal depth at the limbal zone of the lens or adjust the optic zone to avoid limbal wearing. And there could be instances because it acts like a suction cup over the eye at the anterior segment, there could be cases of conjunctival prolapse. Okay, so in that case you can reduce the excessive central clearance or limbal clearance and troubleshoot. So midday fogging is a predominant complaint with most of the scleral lens wearers. So generally you advise them to remove the lens and refill with the solution and refit every 3 to 4 hours. Sometimes every 2 hours also in certain cases. So you need to, if you're giving too much of vault over the cornea, that would also be a cause for midday fogging. So you need to assess the fit very well and not give excessive corneal clearance also. So these are very many solutions. Unfortunately, because of constraint of time, I'm unable to go through all of them. So when you're talking about case analysis for fitting scleral lenses, you need to look into the patient history, the topography if it's available, clinical findings of that condition, deliberate why you need to choose a scleral lens for this particular patient and not blindly jump into saying, okay, this is a case of irregular cornea, I have to fit a scleral lens. That's not your approach. You need to look at the profile of the cornea and decide, will a corneal lens help or a corneoscleral lens help or a scleral lens. If in doubt, start from the corneal RGP lens and move or progress towards a scleral lens. And next comes most importantly fitting and assessment and troubleshoot when need be. So these are the various cases for which scleral lenses were fit of keratoconus, moderate to severe cases of keratoconus in which a corneoscleral lens doesn't work, ocular surface dry eye conditions, in that it works beautifully. So the take-home message is not all irregular corneal conditions require scleral lenses. Pre-fit evaluation is crucial before exploring options. Be familiar with availability of lenses and fitting guidelines. Periodic follow-up is very important. Maintaining corneal integrity is important. Reiterate the importance of care and maintenance during every follow-up visit. Fitting specialty contact lenses is a great practice builder, gives personal satisfaction and patient loyalty. So make a difference to these patient lives as well as yours. So thank you very much. These are